Thank you, everyone. I will be jumping into the topic now. As any important topic, always it will be nice to start with a story. I usually start with a story. So here the story is about a patient, 18-year-old female, who presents to your ER with high-grade fever, a bit breathless. She is in altered mentation. She had been having diarrhea for 3 days, watery diarrhea, large volume diarrhea. That's how this patient presents to you. And on examination, she was found to be febrile, 101 temperature. She's tachycardic, hypotensive. Her BP is 90 or 70. And her GCS is depressed at a score of 9. When incidentally their GRBS was checked, it was showing as 480 milligrams per deciliter. She's not a known diabetic in the past. So remember this scenario. This patient at frequent junctures in the presentation, next 30 minutes or so, we'll be seeing how this patient travels through the treatment part, ultimately how the patient improves and what is the evidence for it each step. So just remember this female who presents to the ER with fever, high sugars, altered mentation, tachycardic, tachypneic, and hypotensive. Okay, so remember this patient. So before the brief background of diabetic ketoacidosis, you can see the picture on the extreme left upper corner. You can see the ward there. These are the wards who are filled with type 1 diabetic patients, young patients. Before 1920s, when the insulin was not actually invented or discovered, at that time it used to be having a almost huge mortality. Almost every patient in a type 1 diabetic, they never used to survive through the adolescence, and there used to be a lot of morbidity and mortality. And thanks to these two gentlemen whom you can see, I think everyone recognize it, Banting and the Best. It was a miracle actually. They discovered the insulin in the pancreatic cells of dog, and they were further with the help of MacLeod, Collip, and other colleagues, they were able to isolate it in a pure form. And because of this, I think there was a huge change in the way the medicine was evolved. As you can just, I'm like picture say more than any 1,000 words. As you can see the extreme right corner, you can see the baby, and when the mother is holding the baby, how emaciated it is, how bad the baby looks. And after the insulin, this is a difference between December and February. Once the insulin was given to the patient, the baby looks so healthy. And this happened to a lot of people over a period of time. So 1920s, that's the reason both of them were awarded Nobel Prize in medicine. So thanks to this gentleman, we'll just pay our gratitude to them and go into the topic. So right into the subject proper in the presentation, these are the headings which I'll be touching. So we'll be discussing the brief definitions, how the diabetic ketoacidosis is defined, what are the clinical features of the diabetic ketoacidosis patient, what is the basic pathophysiology behind it, what are the various diagnostic strategies, how do you manage a patient, and once you know that the patient is better, when do you transfer a patient from ICU to the ward, and what is the transition point. These are the small headings under which we'll be discussing the topic. So why is it important, diabetic ketoacidosis? It was first described in 1886, but as I told you very clearly, showing the picture, till 1920s, it is almost universally fatal. And believe me, it was a miracle at those point of time. And even now, maybe in a developed nation, the mortality may be less, but in developing nations, because of various factors, you can call it resource poorness or maybe unawareness, whatever it may be, there's still a significant mortality. And in some series, it was documented up to 40%, which is huge, especially considering that this disease can be solved easily and treatable. And it carries a huge economic burden in millions and millions of dollars on the nation. And what happens even if the patient is partially treated and incomplete treated, even though the patient may survive this episode, but in the future, there will be a kind of stunted growth, the milestones will be delayed, long-standing sequelae will be there. So there's a huge morbidity. And in the mortality, specifically in the younger group and the adolescent groups are at higher risk of cerebral edema, which is the most common cause of mortality. Whereas in the adult population, it actually, the electrolyte abnormalities are the one which, and associated conditions, which I'll be going through in an interesting scenarios in the next slides. So they are the cause of death. What causes the diabetic ketoacidosis? Just imagine you you're traveling in a ship and suddenly it submerges in the middle of the sea. You're surrounded by a huge water body of sea water, but you cannot drink even a drop of water because it's a salty water. So that same analogy applies here in the diabetic ketoacidosis as well. Even though your sugars are on the upper side in the blood circulating at the plasma level, but still the tissues are unable to use it because of absolute or relative insulin deficiency. And there's a compensatory mechanisms which are acting up and increasing the counter regulatory hormones like glucagon, catecholamines. What do they cause? They cause increased hepatic gluconeogenesis and glycogenolysis. So it creates a kind of spiral circle where the sugars are high in the blood, but the tissues are unable to use. What does the tissues have a backup plan? Here, the lipid comes into the picture where there will be an enhanced lipolysis, which in turn will be converted into the ketone bodies. They convert as an alternative source of energy. But are they foolproof? No, they're definitely not equivalent to the natural mechanism. And at the same time, they have a side effects like it causes a huge acidosis as well. What does these other side effects of these conditions? There's these high sugar values and these things called a kind of osmotic diuresis causing like fluid depletion. That's the reason most of these patients are volume depleted at large volumes. And associated conditions, for example, this may be discovered by an associated myocardial infarction or a pancreatitis. So the associated conditions, especially when they landed into a DKA, they can in turn can have an increased mortality or morbidity without DKA. So all these things combined cause a sequel effect or kind of butterfly effect at the end of the this pathophysiology. What are the various risks and precipitating factors? First and foremost, you need to understand what is the type of patient which comes to you. If it's a type 1 diabetic, it can be an initial presentation. The patient may present to you like a diabetic ketoacidosis, or it may not be like that. Sometimes the patients with type 2 diabetic as well may present to you when especially they are non-compliant with the medications or even and then stop taking insulin, or when they don't understand the sick days. So sick days is a concept where during the sick days, for example, a patient has a fever, patient has some kind of stress on the body like a trauma or something, the stress on the body increases and the sugars actually shoots up. But a naive patient, maybe an illiterate patient may not know that, and they subconsciously what they'll do, unknowingly they'll decrease the dose of insulin, they decrease the dose of anti-hyperglycemics, and it in turn causes a high glycemic state and which pushes the patient into a diabetic ketoacidosis. Associated other conditions like myocardial infarction, CVA, we've seen patients, I think most of us who regularly work in the ICUs, they must have seen a patients who actually presents with a myocardial infarction. When you see the patient, the sugars are high and the anion gap is not explained by the primary condition. And when you go in search of it, then you'll understand that the patient has an associated DKA as well. This applies to the other settings like a surgical setting like appendicitis, pregnancy, and sometimes that may not be very clear to you. The pictures, the patient may be taking a sympathomimetics. They may be recently started on a corticosteroids, especially this is recently we have been seeing after the especially during the COVID state, where the patients were taking steroids at the home and they land up into the DKA. So these are the various precipitating factors which can push the patient into a diabetic ketoacidosis. Once you understand that there is a risk of DKA of this patient, it is basically a few of the hyperglycemic emergencies. How do you diagnose it? So the name explains, it is a self-explanatory name. DKA, that is D is diabetic state where the sugars are high, it is more than 198 or approximately 200, and or the patient may be known to have a diabetes mellitus or may not known to have a diabetes mellitus. This is an exception in another setting where euglycemic ketoacidosis, which we'll be discussing in the last slides. Second must scenario is ketones, presence of ketone bodies. Rather than a presence of urinary ketone bodies, presence of ketone bodies in the plasma or blood is the sine-qua-non or quintessential criteria. So it should be more than 3 millimoles per liter. And third criteria, which is definitively required, is acidosis, defined by either a pH of less than 7.3 or concentration of bicarbonate less than 15 millimoles per liter. So once you know that three of these criteria are satisfied, you know that this patient has a condition called DKA. And this is a new criteria which was given by the British criteria, and some various criteria like ADA, the slightly difference will be there, but the concept remains the same. So again, going back to our initial friend who presents to the ER, what do you want to do? So the first step which you need to do, either in you're handling in an emergency, either in a peripheral setup or in an ICU, you need to resuscitate the patient. So the resuscitation, evaluation of the patient, management of the patient, all of them goes hand in hand, especially in this scenario. So we need to first secure a wide bore peripheral catheters and start volume resuscitation. Always remember, fluid management and electrolyte management always comes before insulin therapy in a diabetic ketoacidosis patient. So this is very important and very commonly done mistake at the grassroots level, which you need to never should be repeated at our level. Central line, it is essential or not, you need not always keep a central line. The indications for central line is basically when the patient has other organ dysfunction, significant acidosis, severe hemodynamic compromise, or when the patient has an associated condition which requires multiple infusions. These are the conditions where you require a central canal, but you can always start with the peripheral lines to always start with the resuscitation with crystalloid. There's no role of colloid. Normal saline is the well accepted and well researched crystalloid in the various fluids. And make sure, as I told you, before you give any kind of insulin, make sure that the potassium values are checked, and it should always be more than 3 or 3.5. So our friend, the step one, the resuscitation was started. What do we do in the second step once you start the resuscitation? As I told you, empty mind may not do too many miracles. So you need to understand where you're going. You need to chart your territory. So you need to go and take the history of the patient, examine the patient. In a focused examination and history taking, you need to ask if there's a drug non-compliance, especially the anti-hyperglycemics, or search for the leading history which could have precipitated the diabetic ketoacidosis. As I told you, maybe a vascular accident, maybe an infection, whatever it may be, or sometimes it may be a first presentation without any other incident factors. And in the physical examination, go and look for clearly the infective foci, maybe a pneumonia, maybe an appendicitis, various kind of things you can always trigger. And in the drug history, always look for history of SGLT2 inhibitors, which are, I think, being increasingly used in the nowadays with their good cardiorenal benefits. We'll be discussing at the last, but make sure that you ask the history of this patient, this drug, because remember, the sugars may be normal with this drug, but still the patient can go into a diabetic ketoacidosis. So again, we go back to our patient. Can you have any other differential diagnosis? So this patient has a gastroenteritis, diarrhea. It could have a gram-negative septic shock, or it can be a severe fluid loss, which can go into a metabolic acidosis. Can it be a honk or hyperglycemic state? We'll come to it. Can it be a pancreatitis? Unlikely. When you other common differential diagnosis for this DKA is high anion gap metabolic acidosis. You can have a combination of alcoholic ketoacidosis, combination of starvation ketoacidosis, psychiatric patients taking a salicylates or other kind of antipsychotics. And the last entity is the renal patients, especially diabetic patients with long-standing diabetic nephropathy. They may have an associated end-stage renal disease as well. Here it will be a huge confusion, which is the acidosis which is dominating. Is it a DKA component or is it a renal acidosis component? So we'll be discussing in detail. The reason for this slide is you need to understand there is a lot of differential diagnosis as well. So is it a hyperglycemic hyperosmolar state or DKA? Usually DKA presents with a significant ketoacidosis where the ketone acidosis is minimal in a HONC or HHS. Sugars are much higher in HHS because the insulin levels are always in a like usually normal state, whereas almost minimal state in DKA patients. The osmolarity will be very high in a HHS. Usually HHS presents in an elderly group where DKA presents in an younger group. The onset will be much more acute in a DKA where it is a chronic condition where the patients are usually elderly. It develops over a period of time and has a very poor prognosis in HHS. And they may present with seizures, and coma and neurological symptoms are pretty common in HHS. And dehydration, it is there in both of them, but the amount of fluid you need to give in HHS is much higher when you compare with the DKA. This patient, we all know that this patient has a DKA. At this point of time, you need to classify whether it's a mild DKA, moderate DKA, or severe DKA. How do you understand? One thing to understand is any patient who has a hemodynamic compromise, who has an organ dysfunction, extremes of age group, like very elderly group, very younger age group, or special groups like pregnant ladies, renal dysfunction patients. These patients, you need to have a very lower threshold to admit them into an intensive care unit. Purely talking on the numbers, mild, moderate, severe DKA, you can classify based on the pH. Severe DKA is when your pH is less than 7 and bicarbonate is less than 10 in severe DKA. And don't go looking for the number of plus in the urine ketones. It may not actually reflect the severity of the DKA. Anion gap is one thing which can actually give you an idea of severity of the acidosis in the body. The more severe it is. Mental state, definitely the more severe the DKA or HHS, the more stuporous or comatose the patient will be. So if we are clear till now, we can will be proceeding to step 3. We resuscitated this patient. We have basically took the history and done the physical examination of the patient. Decided whether to admit this patient into an ITU or in ICU or into the ward. What are the investigations you need to send? To send any investigations in any type of patient, not only DKA, you need to understand the disease pathophysiology and evaluation of the disease. So here we know that this patient has a high sugars, which already we know it. So you need to repeat at serial levels. And obviously we know that there's a lot of electrolyte disturbances. You need to send a basic metabolic panel, which includes a magnesium and phosphate. The reason I kept magnesium phosphate is usually we'll tend to do the potassium and forget to do magnesium and phosphate. And creatinine and blood urine nitrogen, you can do it, but may not repeat it very hourly frequently. You need not every time do an ABG, you can do a VBG as well. Complete blood count may give you an idea about the neutrophil count, amount of infections. Between the serum ketones and the urine ketones, always the serum ketones are the one which is more useful for you. ECG, chest X-ray, try to always do it, because as I told you, many of the times cardiac coronary artery disease, pneumonias, these are missed, and we'll be going and treating the DKA, but forget to treat the precipitating factor. And always better to send a cultures to see if there's an occult infection. So as I told you, these are the numbers. How do you decide the assessment of severity? This slide is self-explanatory. Any patient who has a severe acidosis with bicarbonate less than 5, these are basically very severe acidosis. This patient inherently will be getting admitted into the ICU. So our patient, we send the labs, we done the initial resuscitation in the emergency. We evaluated briefly. And now our management will be starting. We will be going into the initial management and we'll be discussing in the evidence part. So the management has 4 prongs. The 4 prongs are fluid resuscitation along with electrolyte abnormality correction. Second thing is IV insulin therapy. These are the basic 2 steps. Along with it, you need to watch for the complications of DKA, complications of the DKA, complications of the treatment which you're giving, like insulin may cause a hypoglycemia, may cause a hypokalemia, The complications of the fluid you are giving may cause a fluid overload, pulmonary edema. So these are the complications you need to watch for. At the same time, fourth thing is you should never forget to identify the precipitating cause and treat the precipitating cause, without which every time the decay again will not be like reversed. So this is the basic thing you need to give. A to D. Airway, breathing, circulation, we all know. Always try to involve a senior diabetologist team, endocrinology or critical care team or physician team. E is electrolytes, fluid replacement. This is basically a mnemonic which you may remember. So coming to the fluid therapy, we all know that these patients are extremely fluid depleted because of the osmotic diuresis, because of the decreased intake, maybe because of vomitings, pain abdomen, whatever it may be. How does the fluid which you give help the patient? It basically restores the circulatory volume. It will improve the turgidity of the vessels. It clears the ketones into the urine, and it again corrects the electrolyte disturbances when you are replacing with the potassium in the normal saline. And always remember, you can have two conditions where the patient may be hypotensive, where the systolic BP may be less than 90 millimeters of mercury, or the patient may be normotensive. So your approach is when your patient is a hypotensive patient, your approach remains the resuscitation of the patient, like your any other septic shock patient or any other shock patients will be discussing there. Where if your BP is more than 90 millimeters of mercury, you'll be going to replace the fluid at a fixed intervals. At the same time, trying to watch to avoid over resuscitation. So these are the common deficits in the diabetic ketoacidosis or HHS. Almost 6 liters of fluid is deficit in a DKA, whereas it is 9 liters in HHS. Sodium, chloride, potassium, phosphate, all these ions are grossly depleted in both these conditions, where it is much more profound in HHS. So in this patient, what have we done? We initially gave the fluid, as we know. We resuscitated the patient because you remember the patient, as I told you to remember this patient, she was hypotensive. So we resuscitated with a 15 to 20 milliliters of kg normal saline first couple of hours. Then the patient's blood pressure started picking up. After the initial bolus, always you can cut down the fluid. You can go to the baseline fluid. I will be discussing the nomogram in the next few slides. But the point you need to understand is once your initial resuscitation is done, then try to not over resuscitate the patient, because there are some problems like cerebral edema, hypernatremia, these kind of complications may occur. So that's the reason, especially you need to keep a watch on the sugar level as well. Especially once your sugar comes to the GRBs comes to around 250 or something like that, you need to switch over to the fluids which contain dextrose as well. Another thing is half normal saline also may help you, especially when there's a hypernatremia. When you're replacing a potassium chloride also contains a chloride. Basically, it is diluted in a normal saline containing fluid, where it increases the tonicity of the fluid. So you need to switch over to the half normal saline. When you're resuscitating this patient, one thing you need to remember, large volumes of normal saline, as we all know, it creates a kind of hyperchloremic acidosis or non-NGAP acidosis, where you'll be confused whether DKA is again coming back or is it a new kind of acidosis. Your delta gap or gap ratios will help you here. So these are the groups of the patients which you need to admit into the intensive care unit, and central line may be required, and where you need to be very, very careful when you're shifting these patients back to the wards. Remember, any patient who has these kind of pictures, when you're shifting back to the room, it's a pretty dangerous thing. So you need to be very careful. As I told you, the setting where younger group, elderly group, pregnant ladies, heart and kidney failure, or when you have an organ dysfunction. So just a brief review. Your management is on these three lines: diagnosis, where you know that the sugars are high, your ketone bodies are high, and there's an acidosis, and your immediate management can be divided into 3 parts. One is from the zero hour, or from the point you diagnose the DKA, that is 0 minute to 60 minutes, that is in the first hour. In the first hour, your whole goal remains to replace the fluids, preferably a normal saline, evaluate the patient, send a basic panel, try to get the serum electrolytes, especially the potassium bicarbonate and phosphate, and try to correct them to the normal range before you start a insulin therapy. This is in the first part. So this was the part which we are discussing. When you're replacing a fluid, keep a watch on the systolic blood pressure. If it is less than 90, your standard fluid resuscitation goals, like any other fluid resuscitation you do, which applies. And what do you do when the potassium is on the lower side? Try to avoid the insulin at all cost if it is less than 3.5, and to try to take a senior's input, senior physician's input, and it is between 3.5 to 5.5. You need to replace around 50 millimoles. It depends on your ICU protocol, the patient, is it a renal patient or cardiac patient. Whereas if it is more than 5.5, you need to repeat again after hour or 2 hours, and then need to reassess. So we'll just take a hold. Any questions you can again keep in the chat box. So moving forward to the second part, that is after 1 hour to the 6 hours. Here you've done a good job in resuscitating the patient in the first hour. Your aim is to avoid the complications rising from your treatment. Start a proper insulin therapy, cut down the sugars at an expected level. Expected level of decrease in the glucose is between 50 to 75 milligrams per deciliter. And your ketone body should fall at least 0.5 millimoles per liter per hour. If you cannot check if serum ketones at your lab, you can always check a bicarbonate. Bicarbonate should raise at least by 3 millimoles per liter per hour. Every hour you're doing your job in a proper way. If you're not doing that, again reassess the patient and see if something is going wrong. Either it's from the patient side or either it's from the treatment side. So this, I think we've discussed. The fluid, once you resuscitate the initial fluid, maybe you're given a 500 ml or 1 liter in the first hour, then you go and replace with the next 2 hours with the potassium chloride. Always in the next 2 hours, you need to replace with the potassium chloride in the normal saline. The same thing applies. So there, as you can see, 1 plus 1 plus 1 over 2 hours, 2 hours and 4 hours. And after this, once you identify your sugars are falling less than 252 or 14 millimoles per liter, you need to add the 10% glucose or 5% glucose to see that what are we trying to see? To avoid hypoglycemia, because there is something called as rebound hypoglycemia in this patient, which may has a propensity to kill the patient. So here your goal is to balance the osmolality, avoid the cerebral edema, and avoid the hypoglycemia. And you can always cut down the insulin infusion to off. That is, once usually will be starting at 0.1 units per kg per hour, you can cut down to 0.05 units. We'll be discussing the insulin. So what do you do in our patient? We started the fluids, we've seen the potassium, we started the insulin. As I told you, if things are going in a proper way, that means you're doing your good job. That means your bicarbonates are increasing, your acidosis is improving, your ketones are coming down, your sugars are coming down. But if it is not happening, what do you want to do? You just go back to a step, reassess the patient. Usually our approach at our unit has been man, machine, and the circuit. That is something going wrong with the man or woman for that sake? That is the disease flaring up? Is there a sepsis which is worsening, which is causing much more and more DKA? Or is the drug being delivered properly? For example, insulin may not be loaded in a proper way. It may be not stored in a proper way before, or maybe a wrong insulin is being given. That may be a cause. And lastly, connections. Always check the connections. Many of the times we find the circuit may be not properly connected, or you may connect to a cannula where it is actually not, there's no proper flow in the IV cannula and most of the medicine is going out. So just check it, go back and check it again if your things are not working. And rest of them, I think most of us will be knowing the routine ICU care you'll be doing, like thromboprophylaxis, kind of ECG monitoring, all these things. I don't think you're knowledgeable enough to know it. So once you know that, after 6 hours, what you want to do, there are 2 stages, that is 6 to 12 hours and 12 to 24 hours. So in the 6 to 12 hours, obviously, you'll be monitoring the biochemical parameters again. You'll be continuing the IV fluids. Just reassess if you need to give too much of fluid, or you can cut down the fluid. And definitely you need to understand this is a stage where actually the hypokalemia, hypomagnesemia, hypophosphatemia, all these things can occur, especially when the patient is very frail person. So keep a watch on those things in this stage. 12 to 24 hours is the stage where actually most of the settings patient should have been improved by now. By 24 hours, if your patient is still having acidosis, still having ketonemia, definitely something is going pretty badly wrong, and you need to understand what is going on and call a good senior, talk to them, reassess the patient again. And obviously, between this stage, you should not have a DKA. So this is a summary slide where I'll be touching in the last. Don't worry too much here. There's a diagnosis, decision about where to keep the patient, fluid therapy, insulin. You'll be continuing the fluid, you'll be cutting down the fluid, and monitoring for the complications of the treatment. How frequently do you need to check it? Hourly glucose should be done. Bicarbonate and potassium should be done at maybe an hour or 2 hours, depends on your feasibility. Once it comes down, the sugars are falling, you need to be watching for the hypoglycemia. So these are some controversial areas where I thought I'll just put a word here. I think someone is writing something on the screen. If they can avoid it, would be nice. Considering colloid versus crystallite, always your choice is crystallite. Never go for a colloid. Is it a normal saline, or is it a kind of a balanced solute like a RL or plasmolite? There has been a lot of studies, lot of RCTs as well. But at this point of time, the consensus is still the normal saline is the first fluid of choice for the resuscitation. Well read, well studied fluid. So always go for a normal saline if it is if you are reasonable enough. And rate of fluid replacement we discussed. IV bicarbonate, it's a very controversial thing. So very common mistake which is committed at a very like basic level, naive level, is giving an IV bicarb. Never do that. It has a propensity to cause an intracellular acidosis. It can actually increase the sodium to a much higher level, go into a pulmonary edema, and the cerebral edema chances, all of them are pretty huge. So there is no indication of intravenous bicarbonate unless until it's in a dire circumstances where your pH is really low, 6.9 or something like that, where you don't know what to do. Apart from it, don't give it. Intravenous phosphate, when your phosphate is less than 1 milligrams, and the setting is starvation acidosis, when the patient is really malnourished. When you're giving a lot of insulin, the patient may be pushed into a refeeding syndrome. That is the scenario where you will be giving an IV phosphate. And rate of glucose lowering, as I told you, it should be 54 or 50 to 75 max. So most of our presentation has been like briefly completed. Now I'll just revise it in the last 5 or 6 slides. So what are your targets? Your targets are reduction in the blood ketone concentration, increase in these are the targets. You need to have a target before you start your battle. These are your targets. Correction of electrolytes we have been discussing. So one thing you need to remember is there is a correction factor of sodium. Especially there's something called as pseudo hyponatremia, when your sugars are high, you need to correct it. So don't keep on correcting it unless until you know the actual value. Rest of them, I think they're self-explanatory. This is a nomogram. I think we seen in the how much potassium you need to replace. I think it's self-explanatory, where more than 5 or 5.5 you won't be treating it, whereas less than 3.5 you need to treat it with 20 to 40. Between it is depends on your clinical decision. I think we discussed 3 of them. So insulin therapy, 2 slides about the insulin therapy. There is something called as fixed rate insulin therapy, and there is something called as variable rate insulin infusion. Fixed rate insulin infusion is 0.1 units per kg per hour, where it is fixed for every patient, which is the standard of care for any ICU all over the world. So it is a brief table. You can always remember 40 to 49 kgs, around 4 units, 5 units, 6 units, as you can go through the slide, no, you can understand it. Any patient who requires more than this, more than 0.1 units per kg, you need to again go back, sit with your senior and see why this patient is requiring so much of insulin. Okay. So the second part is the part where your sugar comes down less than 250. There you'll be cutting down to the half of it, where you're giving 4 units, you'll be going to the 2 units, and vice versa, like so on and so forth. Whereas variable rate insulin is where once the patient, you know that the patient is stable, you will be changing the insulin as the sugars change. So one common thing, and which may has a dreaded complication of death, is hypoglycemia. Always remember it. So insulin acts at 3 levels. It suppresses the ketogenesis, it reduces the blood glucose, at the same time it corrects the electrolyte disturbances. As I told you, the first slide, it's a life-saving therapy thanks to Banting and Best. I think these all, most of them we discussed. One point I would like to highlight in the pediatric population is they are very high risk of cellular edema, especially the cerebral edema. So any pediatric patient or in a very younger to adolescent group, if the patient had a new onset seizure, a new onset altered mentation, when you're giving a treatment for DKA, suspect a cerebral edema and act quickly. 3% normal saline or mannitol, or basically whatever is the routine anti-ISCCM measures you need to give. No, so you need to be aggressive in it, because it again has a propensity to kill the patient's cerebral edema. So our patient, the patient who came in the first part, we treated them, we gave insulin, we given the fluid. How do you know that this patient has improved or not? So very common things, 4 indicators are: the patient feels better, they'll be taking oral food, usually at least 2 meals they'll be good to take, and the anion gap will be usually closed. As we seen in the initial set, the anion gap actually reflects the amount of decay. So the anion gap is closed and the bicarbonate will be more. So these are the basic indicators that the decay has resolved. And once the decay has resolved, one common mistake which can be committed is stop the IV infusion immediately, insulin infusion. And once we stop it, then switch on to the subcutaneous insulin. So which is a common mistake to do. Remember, it takes a bit of action. It's a time for subcutaneous insulin to act. So intravenous insulin infusion should not be stopped immediately. It should be stopped only after 30 minutes after your subcutaneous short-acting insulin has been given. Okay, this is a pretty good point to remember for you. And at the same time, if the patient was already on long-acting insulins, don't discontinue them. So we see in this patient, we treated them. Now that we know that this patient has improved, the decay has resolved. What are the complications which can occur? We all know hypokalemia and hyperkalemia are pretty known things to occur. So you need to make sure that they won't be there. And if they are there, you need to identify them in a right time and treat it. Hypoglycemia and cerebral edema we have discussed. Other less commonly recognized complications are venous thromboembolic diseases, especially when you keep a central veins. For example, you keep an IJV or femoral central line, the thrombosis may be there at this point because it's a hypercoagulable state, and transient AKA may there, but usually the fluid resolves it. If you are overzealous in your resuscitation, it may land up into pulmonary edema. Pancreatitis or raise in the pancreatic enzymes are pretty common, or on the other side, pancreatitis can also present a decay, precipitate into a decay. Cardiomyopathy can be there. They may go into rhabdomyolysis, and GI bleed is not pretty uncommon. So last 2 slides about the patients. This is a special group discussion where when the patient has a renal disease, what do you want to do? Why is it important to discuss separately? The insulin is cleared by the kidney. So obviously when your kidney is impaired, what will happen to the insulin? There will be a relative increase in the insulin levels in the plasma. That means the ketoacidosis part is actually less when you compare with the non-renal patients. That is, the insulin will be staying in the plasma much more. And another confusion which may occur, as I told in the first slide, is there may be a component of renal acidosis because of the chronic metabolic acidosis, which will be treated by the dialysis or which will be treated by the bicarbonate. Here you'll be confusing how to treat and what to treat. Another one relevant point is the beta hydroxybutyrate concentrations are actually less in the end stage renal diseases, and you need to depend more on the anion gap and glucose levels, whereas other values are not that relevant. Fluid replacement in the renal patients, you need not be very aggressive, and you should not be very aggressive like when you are replacing in the patients of other non-renal patients. In fact, in some settings, you may not be needed to give the fluid as well. And one thing is there will be an inability to develop osmotic dialysis because of the kidney failure. So dialysis associated hyperglycemia and ketosis can occur without a presence of dehydration. So the insulin remains the standard of care there. Potassium, the hypokalemia is not that common, and in fact hyperkalemia may be more common in renal patients. So don't go and aggressively in treating the potassium replacements like a non-renal replacement patient. Last 3 slides in the presentation about the special settings, like there is something called as ketosis prone type 2. You may not always have a type 1 diabetes mellitus presenting into a DKA. So it need not be our classical patients like your first patient, no, we seen, right? It may not be like that. Okay, it can be a type 2 patient who presents with a DKA as well. So this is called as Flatbush diabetes or ketosis prone diabetes. It has a special pathophysiology. Remember, one thing you need to remember is this is a special setting where the treatment remains the same, insulin and fluid replacement. But after the specific treatment, after 1 setting or 2 settings after the insulin treatments, usually patients may go back to the oral hypoglycemic agents, and they'll have a routine course as any type 2 diabetes mellitus. So coming to the end of our presentation, last story to tell you. So I'll be signing off with last story. So this is a woman in 40 years, type 2 diabetes mellitus, being treated with the metformin, pioglitazone, and empagliflozin. This is a SGLT inhibitor. So basically, she is admitted for moyamoya disease and some vascular procedure, extubated and transferred to the intensive care unit. Post-operatively, she developed a slurred speech, diagnosed to be having a cerebrovascular accident, resuscitated with fluids, standard of care. Next 24 hours, this patient continues to develop a progressive metabolic acidosis. The pH continues to be falling down. The pH is 7.01, whereas the anion gap continues to rise onto the higher levels, that is approximately 27. You usually treat in a vascular patients, usually you'll be thinking about lactate acidosis, but here the problem in this patient was the lactate was normal. So as any other routine intensivist, we have started a bicarbonate for this patient, but still the patient continues to be deteriorating. So here, what do you do when you don't know, like you're doing something unknown and you're failing there? As I told you, always you step back and reevaluate. Here, the clinicians have done that. Presence of near normal blood glucose concentration in this patient. Initially, they thought the DKA was not possibility, but when you go back and saw the history, this patient took the empagliflozin 18 hours before the surgery, and sometimes it may act up to days, SGLT inhibitor. And the urine analysis revealed ketone bodies, and the plasma ketones were also positive. So the diagnosis was euglycemic DKA, and the reason was SGLT2 inhibitor. And once the patient was known to be having a DKA, obviously the treatment remains the same and it was treated. So your point is never to miss this one, even it is rare. Basically, this drug creates a condition of insulinopenia. At the same time, it creates a glycosuria where they'll be dehydrated and causes a DKA. One common condition which you encourage, starvation ketoacidosis, where the patients are malnourished. They may be having an associated diabetes, but usually this patient will be chronically taking less because of various factors, and this starvation ketoacidosis may mimic a DKA. Here, one thing you need to do is the addition of exogenous insulin. If you do in this patient, if you are very aggressive in treating with this, thinking that it is a DKA, it may push the patient into hypoglycemia and refeeding syndrome. So the treatment remains treating with a carbohydrate like glucose supplements. Alcoholic ketoacidosis is the last differential diagnosis. The common differentiating factor is where usually the blood glucose is usually low or normal, whereas significantly high in DK, provided you know that SGLT2 inhibitors. So remember the special groups. And the take-home message for you is the treatment, the diagnosis. Diagnosis is based on the 3 factors, as I told you: elevated glucose levels, presence of ketones, low pH or bicarbonate. Decide whether the patient is fitting into the intensive care unit or into the ward. Be good in fluid replacement, follow the norms, and at the same time avoid the over resuscitation. Always collect the electrolytes, especially the potassium, before you start the insulins, and continue to replace the fluid. And once you know that the sugars are fallen to 250 around R, then start the dextrose containing solutions, and have a specific protocol for your intensive care unit, how to monitor the sugars at how frequent level, bicarbonate frequent level. And once you know that your DK is not resolving, go back and re-evaluate, and don't miss the conditions like euglycemic ketoacidosis, starvation ketoacidosis, and alcoholic ketoacidosis, where your clinical decision may save the patient. Thank you, everyone. Thank you for patient listening. I think I'll be free to take the questions after the next seminar. Thank you.
Yeah, thank you, Dr. Deepak. I think it is a wonderful presentation, very lucidly described, well understood. So the take-home message is very, very clear. I think whenever the patient comes to us for some kind of diabetic emergencies, so the first thing is to anticipate, and there should be a high index of suspicion, which is very, very important, because all the decay may not present with high sugar. That is what you have also described in your lecture. And the second thing is to know how the burden of the problem is, how severe it is, depending on the anion gap and the acidosis. And third is to categorize into different categories, like whether it is a mild, moderate, severe kind of decay or hyperosmolar coma, and treat them accordingly. So the management is also very important, and simultaneously to know the complications like thrombotic states, like cerebral edema, and like different neurological presentations. So I can say diabetes is not only a single disease, diabetic ketoacidosis, but rather it is a multi-systemic involvement. It is a syndrome. So one has to look at every aspect of the patient, starting from the cardiac evaluation, starting from the nephrological point of view, because they may find sometimes the creatinine and BUN may be very high, and this is fallaciously high because of the presence of ketone bodies. There may be high counts, but there may not be any infection. And fever is sometimes very, very common. The decay can mimic like acute abdomen. It can mimic like acute pancreatitis. So all these things need to be ruled out. So it is a multi-systemic involvement. Very nicely described. I think we'll take the questions at the end of this session. And now I'll invite